Thank you. It's certainly an honor to be here, and it's a privilege to be here. And it's one of the topics that are near and dear to my heart, because not everything can be answered or should be answered in a randomized trial. And I think one of the things that we want to point out and have a discussion on, when is the most appropriate study designed to use a cohort study to provide information that you need in order to improve outcomes and improve patients. And I think if we can get that message across and see what we've learned and how that has helped impact patients, I think that would be very valuable. So we're going to try to be a little aggressive here. We're going to try to have, we have a number of speakers that are truly outstanding, and we want them to just give a little high view oversight of their area of research and what they've learned from it from a high area, and then maybe ask a question or two, and then we'll come back to the questions at the end. So what person I'd like to lead off is Rick Wright, who is intimately knows Moon. He's been a part of Moon since the beginning. It's been my right hand. And Rick runs the NIH-sponsored MARS, which is revision ACLs, which has a much higher, he'll tell you, prevalence of having post-traumatic OA. So with that, I'll let Rick is the chairman at the Vanderbilt Orthopedics in Nashville, Tennessee, and I'll let him begin.
Thanks, Kurt. I'll pull up my slides and get started. I appreciate the chance to talk, and as Kurt said, we've had a lot of success with cohorts. It's not the best way to answer all questions, but it has worked well for us. And this will be mainly about Mars because of the arthritis angle, but Moon led to Mars, which you will see. So we found that revision ACL reconstruction consistently had worse outcomes, patient-reported outcomes, just about any outcome measure you want to look at than primary ACL reconstructions. It was the consensus of the people that came together to form Mars and wanted to study this. Kurt and I wrote a couple and did a couple studies together where regardless of any other factor, if you had a revision, it was the strongest predictor for a worse KOOS score. Then we looked at 5-year outcomes of primary and revision ACL reconstructions, and the sheer fact that you had a revision was the most significant predictor of a worse outcome. But there was really an unbelievable lack of any good revision ACL data. There was really no level 1 or prospective studies that had evaluated why this may be occurring. So we had success with a prospective longitudinal cohort in Moon, and we know that in our cohort, when we were doing multivariable analyses, that we needed 10 to 15 subjects for every variable that we included. And with revisions, there's significantly more potential variables than in primary ACL reconstructions. You've got just a lot more going on in these patients, and so we knew we needed, a lot of patients, and we knew that 10% of the Moon cohort was revision. So if we were ever going to get numbers high enough, it was going to take a bigger effort than Moon from a standpoint of surgeons involved, because even busy sports surgeons like Kurt or people that you know around the country may only do 5 or 10 revisions a year. It's only going to be, even in a busy practice, about 10% of their ACL reconstructions. So as we say, a single Moon wouldn't do it. 90%, over 90% have either grade 2 or worse articular cartilage pathology or a meniscus tear, and 60% have both. So this is a beat up knee cohort that is already demonstrating at the time of revision a significant amount of articular cartilage damage, arthritis, however you want to think of it. So this is really a big factor for these people, and we believe a big part of the reason they don't do as well. So this cohort is a significant osteoarthritis cohort, much more so than the primaries. We've analyzed, and we're currently in the process of submitting our analysis of articular cartilage pathology at 6-year follow-up. So we have 1,234 patients that enrolled in the cohort, and we now have them all 6 years out, and some of the cohort has now reached 10 years out, but we've been able to finish the 6-year analysis of the entire cohort for its impact on patient-reported outcomes, Mark's activity, KOOS, and WOMAC. And as you can see, and these are p-values of negative or worse outcomes in these patient-reported outcomes. And as you can see, probably interestingly, the most significant area that results in patients feeling worse or reporting worse outcomes is in the patellofemoral joint. The patella and the trochlear groove consistently predict worse activity scores, worse quality of life scores, sports recreation, stiffness, pain on the WOMAC. So what we're finding is that articular cartilage damage that we identified at the time of revision at 6 years now is really resulting in worse patient-reported outcomes. So our ability to figure this out, deal with it, potentially address it more appropriately at the time of revision reconstruction could definitely impact our patients' outcomes as we follow them after surgery. So that's a quick overview. Kurt had asked for just a quick overview and a little bit of a highlight. So I'll end with that and look forward to hearing the other speakers and happy to answer any questions.
Is there any quick question for Rick that people want to ask right now? While you're thinking about that, Rick, what is the most important aspect you think in learning from the cohort? What did the cohort model teach you in Mars or in Moon for that matter?
Well, we've learned a lot. I think what we learned is that using the cohort model, we can include so much more data, variables, and I think that for many of us, the most important question was graft choice, because we weren't sure what graft would work. In fact, you and I kind of approached it differently, and neither one of us knew, if one was right or wrong or better or worse or whatever. And so we were able to, if we had randomized graft choice, I think we know in orthopedics it immediately results in a less than 50% participation rate. And we had a 98, 99% participation rate. And our graft choice laid out where it was 25% bone, tendon, bone, and soft tissue allograft, and 25% in each group, and 50% overall autograft, hamstrings and patellar tendon. And so we had 1,200 people really divided up into 4 equal groups, 25% each, and could really address that question. And we probably would have never gotten even 300 or 400 participants if we'd done a randomized trial. So I think, and the ability to include 75 other variables on top of graft choice is probably what's been most satisfying, the ability to answer multiple questions with one study.
So that 2 questions. One was, are reduced outcomes compared to primary reconstructed patients or compared to baseline? And came in on the chat.
Let me look at the chat.
That's the one from Josh Stefanik.
Yeah. Cartilage lesions in the patellofemoral joint. The incidence actually is fairly equal across all 3 compartments, slightly more common in the patellofemoral joint. What this says is that when it's in the patellofemoral joint, at whatever rate, it more commonly will cause worse outcomes. That when you have it, your patient-reported outcomes will go down. And it was a stronger predictor of a worse outcome than similar disease in the medial femoral condyle or lateral femoral condyle or tibial plateaus.
Rick, this is Lynn. Just real quickly, was there a difference by graft?
Yes.
This is part of what Josh is getting at because he's studying this.
Yeah, so at 6 years, odds ratio 3.78 times higher rupture rate with an allograft versus autograft.
Oh, no, I'm sorry. I was asking about the patellofemoral OA.
Is there a difference in the, you said
By
graft.
graft in the disease in the patellofemoral joint?
Is there a difference in the graft? No, we have not
No.
seen a difference with allograft or autograft. And in fact, Chris Kading has looked at that too. And interestingly, frequently you'll see more patellofemoral disease with an allograft. So we have not noted a difference in incidence of chondral lesions.
Patellofemoral, yeah, awesome. Thank you.
Okay.
So our outcome scores typically are 10 to 15 points below what a primary would be, which exceeds the minimal clinically important difference for every score we looked at. There's really not a revision study out there where the patient-reported outcome scores would equal those expected with a primary. And the other question, how many years after primary ACL reconstruction was the 6-year follow-up? So the average time from primary to revision was over 2 years. And then the follow-up, the 6-year follow-up I'm talking about is from the point of revision ACL reconstruction. So 6 years after the revision, and across the cohort, the median was about 2.6 years after their primary reconstruction.
All right, thank you, Rick. If you appreciate that, we can very much move on to our next speaker.
Well, thank you so much to the Arthritis Foundation and the OACS organizers for the opportunity to present our research today. I'm presenting on behalf of a large team. Some of the key organizers of this study are shown on this slide, but it takes a much larger group to make a study like most happen. It's been a very successful study. I'm aware of 184 manuscripts that have been published to date, and over a dozen are currently being drafted. So the Multicenter Osteoarthritis Study, or MOST, is a National Institute on Aging funded prospective longitudinal observational study of people with or at increased risk for knee osteoarthritis. The goal is to identify risk factors for osteoarthritis, and for those with the disease to identify modifiable factors that might reduce the disabling impact. Among the risk factors for disease, MOST has focused some of its examinations on physical activity, systemic as well as local inflammatory factors, muscle weakness, meniscal tears, nutritional factors such as magnesium, vitamin D, E, and other, leg length inequality, and body composition. Among these, quadriceps weakness, synovitis, leg length inequality, high bone mineral density, and meniscal tears, even when asymptomatic, have been shown to increase disease risk. As I mentioned, this is a longitudinal study. The first portion of MOST took measurements at baseline and 30 months and had a telephone visit in between at 15 months. The second portion of MOST had added a 60 and 84-month visit, as well as a 72-month telephone follow-up. And then the third portion added 144 and 168-month visits, also with 152 and 160-month phone calls, where we collected things like WOMAC and KOOS and other important factors. I'd also like to mention that the retention for MOST has been excellent, with over 91% retention of contacts at the 84-month visits. That's over 91% of those who are still living. At the beginning in MOST, at baseline recruited 3,026 men and women age 50 to 79 years old from the general population surrounding Iowa City, Iowa, and Birmingham, Alabama. Those are our two clinical centers. We also have a data coordinating center at the University of California, San Francisco, as well as a data analysis center and X-ray reading center at Boston University. Numerous measures have been taken, which a full report of it doesn't fit within these 3 minutes. But we had imaging measures, joint position sense, biospecimens, physical examinations. In the second portion of most, we started drilling down more on quantitative sensory and vibratory positions, perception thresholds. Also looked at muscle coactivation, balance and falls. And then in the third portion of most, in addition to we'd started with the 3,026 members, and we brought back 2,029 members of the existing cohort and added an additional 1,525 new members of the cohort at the 144-month visit. It's also interesting to note that over the 168 months we've followed the cohort so far, there have been 1,071 knee replacements. Many findings have kind of met of most. So again, it doesn't fit within the 3 minutes, but I thought I would focus on quadriceps weakness, which is one area that we've studied. Quadriceps weakness has been shown to increase risk for symptomatic knee osteoarthritis, osteoarthritis progression by joint space narrowing, worsening self-reported function. Adam Kolvenar and Joff Stefanik found increased risk for worsening lateral patellofemoral cartilage damage. Jose Rubio, Devyani Misra, and others also found radiographic and symptomatic knee osteoarthritis increased risk synergistically with obesity. And Catherine Bacon, Britt Allen Oisted, David Felsen, and others have looked at the effect of quadriceps weakness on physical performance being related non-linearly. Interestingly, all of these findings were found in women, but not in men in the cohort. We've also drilled down on these findings to see, are these findings explained by muscle mass, joint position sense, or other aspects such as coactivation, and those factors haven't been explanatory. It's been very helpful to have such a large study over such a long duration to really drill down on some of these questions and subgroups within the cohort. We'd like to acknowledge the 4 centers and grants that have been funded by National Institute on Aging. The most staff and participants have been so loyal to the study and donating their time and effort. And the most data, although it's mostly been looked at by internal investigators, is available online. So you can look for that at the link below if you'd like to study this cohort as well.
Thank you for that great high-level summary. Are there questions from the audience that we can take now? So what is the one biggest surprise that you've found in the study that you didn't expect to see, Neil?
Well, I mean, I think there have been a lot of surprises. I mean, one thing that I mentioned was that it started out being a study looking for risk factors for who's going to develop osteoarthritis. And so only 1/3 of the cohort had OA at baseline, 2/3 we were waiting to see if they developed it. And over the duration, it's sort of turned into a really great observational study of risk factors and who's going to go for TKA, because 1/3 of the cohort ended up going on to that so far.
Great. I don't see any, I'm sure there'll be more questions that'll come up.
I think it'll be good if we talk over one of the things that you guys have really shown that has certainly been my, I don't know, pet peeve's not the right thing, but like my target for rehab is quad strength being such a big player. Mm-hmm. And the good thing about looking at this across these, your cohort in particular, it's very large, is that's something we can fix. Mm-hmm. Right? We can't fix a lot of other things, but we can fix that. So,
right.
The fact that it just consistently still keeps coming up as such a big player, I think is very exciting from a rehab perspective, which is my bailiwick, obviously, that it is something we can alter. It's also, I don't know how
other
the
than
surgeons.
obesity, it's the only modifiable risk factor that has really been found so far.
Yeah, and it's probably easier to modify than losing weight. You know, from speaking from personal experience. It's nice to hear that. There's a couple of these players that just keep rising. Sorry, I gotta put my video back on. That just keep rising to the top. Quad strength seems to be one. Getting full knee extension back after a intra-articular knee injury. Those all seem, they're all fixable.
Mhm.
So Neil, there's a question from someone you know very well in the chat box. Can you see the chat box?
Yeah, I see it. So the main inclusion factors for the original incarnation of MOST were pain on most days of the prior month, being obese or overweight, or having either a knee injury or surgery in the past. When we went to the newer cohort, then there were additional factors. So we were actually looking at younger people. So we went down to age 45. And also we're looking for people who had minimal pain and KL grade less than 2. So we really focused on who didn't have pain or OA yet and who's younger, because of course it's of great interest to diagnose risk factors earlier and, deal with this disease before the cat's out of the bag, so to speak.
Okay, terrific. Thank you. Let's move on to our next speaker. Tunisia will talk a little more about OA from a little different perspective, from maybe the perspective of pain, and correlating pain and imaging is always a very, very dicey criteria to do. So,
Great.
welcome. Thank you.
Thank you, Kurt. So we all know about the structure-symptom discordance, and as Kurt just said, it can be quite dicey. And we've understood that this is largely because of the fact that pain is multifactorial. And because pain is multifactorial, disentangling joint pathology, the relationship of joint pathology to OA pain has been challenging. But many of you know we've used a method of a within-person knee-matched approach to try to disentangle this. But what I decided to do today to focus on in my 3 minutes is on these neurobiological mechanisms. Sorry, can't see the arrow here. To focus on the neurobiological mechanisms that can contribute to the pain experience in osteoarthritis. So we've taken an approach of looking at neurobiological mechanisms by focusing on peripheral sensitization, which refers to alterations in peripheral nociceptors. And we can assess this functioning with using a handheld ergometer to measure pressure pain threshold. Central sensitization refers to alterations in the neurons within the central nervous system. And we can assess this with temporal summation, which we do by using a series of weighted probes. And if the pain increases after that train, that indicates there's temporal summation. And both of these are a functioning of the ascending pain pathways. And then there can be descending inhibitory modulation. And we have a protocol for this, but unfortunately 3 minutes won't allow me to review those findings. So first I'll share the pressure pain threshold and temporal summation result being associated with pain severity. When we used the handheld ergometer, we found that those with the lowest pressure pain thresholds at the knee, meaning they're most pain sensitized, they had a higher risk of having frequent knee pain and more knee pain severity. And so this indicates peripheral sensitization. We found a similar result at the wrist, a distal site unaffected by OA, and that indicates central sensitization. For temporal summation, again, this using the series of weighted probes, we found that temporal summation present at the wrist or patella was associated with pain severity. And interestingly, contrary to our hypothesis, was not associated with radiographic OA. We've also been interested in understanding whether specific pathologies contribute to sensitization. And we found that bone marrow lesions reflecting mechanical issues were not associated with sensitization, whereas inflammatory lesions such as synovitis and effusion were associated with sensitization and increased the risk of its development. And then the final study I want to share with you is work that Lisa Carlesso did with me when she was a visiting fellow on pain susceptibility phenotypes. We were interested in why some people only have intermittent activity related pain, whereas other people can develop persistent knee pain. So we looked at people who are free of persistent knee pain, and we wanted to know if there were features or clusters or groups of characteristics that predispose them to developing that persistent knee pain. And so we performed a latent class analysis and agnostically identified 4 different classes. One of the classes was largely dominated by having pressure pain threshold, low pressure pain thresholds, meaning they were pain sensitized. Another group was dominated by having temporal summation. And then the other 2 groups had lesser degrees of sensitization. What really surprised us was that there was no difference between these groups in widespread pain, pain catastrophizing, depressive symptoms, or poor sleep, basically very similar across the groups. So remember, these were people who were free of persistent knee pain at baseline. Over 2 years, when we look at these 4 groups, we found that this group that had pain sensitization by pressure pain threshold had a 2-fold increased risk of developing persistent knee pain over 2 years, indicating that pain sensitization can predispose to developing persistent knee pain. So that was a very quick high-level summary of some of our published findings. QST measures are associated with pain severity, irrespective of radiographic severity, are associated with specific inflammatory pathologies, and have an important role in pain susceptibility. And with that, I'd like to acknowledge the funding. Neil outlined that most data are publicly available, and I'd be happy to address any questions. Thank you.
So hopefully people put something in the chat box. What was the most surprising finding that you observed or didn't expect to see?
Yeah, so I know I had to do that very, very quickly, but we modeled our studies of pain sensitization in thinking about how pain sensitization occurs in animal models. In animal models, joint injury or chronic inflammation can lead to sensitization. Now, we cannot do electrophysiologic studies in humans. We can't interrogate their spinal cord and the nerves. So we use these QST measures as a proxy for understanding those mechanisms. So what I was most surprised by is that we hypothesized that the more severe osteoarthritis, the longer duration of osteoarthritis that one has, they would be more likely to be sensitized. We thought this was a state that could be induced. If you have enough peripheral stimuli, enough peripheral nociceptive input, you get sensitized. We did not find that. And in fact, the pain susceptibility phenotype shows that people have sensitization pre-existing that can lead them to develop different pain experiences. So this indicates that pain sensitization is more like a trait that someone is inherent to someone potentially and gets manifested once you have pathology. There's a question from David Felsen in the chat. Does pain sensitivity account for post-knee replacement pain? So this was another big area of interest for us. 20 years ago now, there was a report of people after hip replacement having normalization of some of these altered pain mechanisms. And there was a more recent report in knee replacement participants, but these were very small studies of 13 and 20 people, and they all had pain improvements post-knee replacement. And we know that about 20 to 30% of people have persistent pain post-knee replacement. So we looked at this in our larger MOST cohort, and we found that if someone had evidence of temporal summation, which is an ascending pain facilitation indicator, or they had inadequate descending inhibition, meaning they have inadequate dampening of pain signals, they had worse pain post-knee replacement. So while post-knee replacement pain persistence may be multifactorial, at least some component is driven by these central nervous system mechanisms.
How would we dissect out the contributory factors to pain in people with everyone has significant knee OA? So you have individuals that we all see that have at least radiographic, which is a very crude way of looking at it. They seem to have the same, maybe they're all KL3. but they seem to have very different levels of pain, even when you look at the MRI. And how do you account, what things do you think are going on that account for that person's level of pain? Could you?
Yes, I think that's a really important and fundamental challenge in osteoarthritis. So in my first slide, I indicated that pain is multifactorial. And so we know as clinicians that if we don't address sleep and mood and coping skills, then they may not get as much symptomatic benefit as someone else who doesn't have issues in those regards. For many years, people have been advocating for a mechanism-based approach to OA management. And so what are the tools that we have to identify what is at play in an individual? So we are really still without clinical tools to assess this. And I think this is also a big struggle and challenge for clinical trials, looking for a D-mode therapy that would also have symptomatic benefit. If someone has this much pain, how much of that pain is due to sleep, mood, coping, et cetera, and how much of it is specifically due to OA or these neurobiological pain mechanisms? And so, I think we just need to continue developing tools that we can use clinically to try to subphenotype people.
Yeah, you have 2 more questions in the chat box.
Okay. Something about gender and BMI. Did other more general factors also correlate to your subtypes? So all of these results were adjusted for potential confounders like gender and BMI. And there is a difference between men and women with regards to pressure pain threshold, and we accounted for that in the way we do our analyses. In terms of the subtypes, I'm not sure, Terry, if you're referring to the pain susceptibility phenotypes. There were more women in this class that had increased risk for going on to develop persistent knee pain. And then the next question, how do you interpret findings when participants have impaired PPT and CPM but normal TS? So there's no clear definition of impaired PPT. We don't have a biologic threshold. So it's not clear that you can classify someone as having impaired pressure pain threshold. We usually look at it in comparison with a sample. But again, these are tools that we infer certain mechanisms. So it may be that, we don't think that pressure pain threshold and temporal summation are assessing exactly the same specific pathways.
Great. Anything you'd like to add? Any you gave us certainly given me a great education in a short time. A lot of things to think about in management. Anything that you'd like to add? Or
well, sort of piggybacking on our discussions in yesterday's OACS sessions about needing to bring some of these tools into the clinic and importantly into clinical trials to see whether or not these tools are helping us to phenotype, to understand response to therapy, response to surgery, and can we identify, using these tools, identify people most appropriate for particular interventions.
Terrific. Thank you so much, very much. Our next speaker, I believe, is Lynn Snyder-Mackler. We'll talk about Rehab in the Delaware Oswald cohort, things learned from that outstanding study.
Thank you. Jason, you have this, right? There I am. Can everybody see it?
Yes.
Okay, great. So this is this study is 2 physical therapy PhDs, me and Myron Risberg in Norway, and Michael Axe, who's an orthopedic surgeon here in Delaware, and Lars Engebretsen, who's an orthopedic surgeon in Norway. And the way that this all got started, actually around when Kurt was starting Moon, a little bit after, I think, right, Kurt? You guys at 20 now or close?
Yeah, 20.
Yeah, so we're a little bit behind you. But we were very interested in the rehab piece, and we were also very interested in the fact that the practice patterns are very different in Scandinavia than they were in the US, which is, in the US, it's a young athlete has surgery. That's just what happens. Except in the odd time frame when, you want to try and get them through that season, that last competitive season, senior year in high school, last year of college, something like that. But they did rehab as a matter of course before people had surgery. So we thought we'd take a look at this. So we had, can you flip the slide, please? Thanks. So we have 300 participants. This is not an all-comers in terms of everybody who had surgery. Everybody had surgery. These are 300 participants. They were all level 1 and 2 athletes. So jumping, pivoting, cutting sports. We had 150 in Norway, 150 in Delaware. Unlike many of these other cohorts that you're hearing about that have thousands and thousands of participants, we have a small number relatively, but we have very deep data. So we have clinical data, we have functional data, we have radiographic data. We have patient-reported outcome measures across all of the domains, including things like, the psychological stuff, which is pretty sexy right now. And then we also have physical activity measures in our tenure group, both the IPAC as a PROM and then Actigraph. This is, Kurt already said that I'm going to talk about this a little bit, is that this is how practice happens, right? Through a process of shared decision making. The doctor, the therapist, the patient, in many of these cases, the patient's parents are making a decision to choose the ultimate management of their injuries. It was very interesting. We really anticipated at the beginning that all of the Delaware cohort would have surgery, and that about 2/3 of the Norwegian cohort. But it turns out when we did this protracted rehab, about 1/3 of the Delaware cohort didn't have surgery either. So that was really interesting. It just meant like if you, and the biggest predictor of when they didn't have, that they could continue to progress with rehab is that they felt good after a couple of months. So it's very interesting because in this country, we tend to roll people into surgery fairly rapidly as soon as their knee is quiet, no effusion, full range of motion. What we found is, wow, it's pretty interesting that the better they are going in is the better they are coming out. All right, next. So we're, again, focusing on rehab effects, on clinical path, and then on both surgical and rehab outcomes. And our 5-year data, which is impressed right now, shows that when you let people make these decisions, these informed decisions, they all do fine. Most of them do fine. We have a very low rate of ACL re-injury. We have a low rate of contralateral ACL injury, and interestingly, they're all happy. Again, when they get to make these decisions themselves. So we're going to continue to follow them. Can you flip one more time for me? I think Kurt, you can probably chime in here, but I recall when you first submitted Moon to the NIH, one of your goals was for Moon to be a benchmark for comparison across a lot of studies, just sort of laying out there as a benchmark. And we've been doing that, benchmarks against Moon, against the UK National Ligament Registry, and the Norwegian National Knee Ligament Registry, which is the bottom one. And it's actually really interesting to be able to try and benchmark our data. And the other thing is that because we have these deep data, we have a lot of these physiological measures. I know, Moon, Kurt, how many do you have in your in-person cohort?
425.
Right, so even bigger than ours. So they could do the same thing, which is then we could get to what are the things that are driving bad outcomes. So that's what's helping us using these other registries. We have these outcomes, and we can help figure out on the rehab side, are there things we could do that can make this better? The other thing, and this is a problem, solving problems, is not this past March, but the March before, at the American Academy of Orthopedic Surgeons ACL outcomes group, or ACL registries group. I was listening as people were talking about the fact that you can't compare among all these registries because they aren't all using the same patient-reported outcomes. So we have spent the last, I don't know, a little bit over a year with Moon, with the UK to try, because these three registries, or these three cohorts, have both KOOS and IKDC data. And we've developed a crosswalk now that you can, with population-based data, we can translate the KOOS to the IKDC, which I think is going to, for the people who really love big data, is going to be really helpful. I mean, we meaning we at Delaware are not going to use it, but we are extremely excited to have solved this problem. And solving this problem happened because of these registries and cohort studies. I think that's it. Is that the answer? Do I have one more slide? Yes. Okay. So the other thing, and Kurt already talked about this, cohorts purposes are not just like to inform RCTs. Sometimes cohorts are the right methodology to answer the question. People don't want to flip a coin about getting surgery or not. They really want to have an informed decision about what's the best path. So I think cohorts are the way to answer this. And I think that's it. Thank you. Thank
you, Lynn, very much. I guess one of the, some of the things that we learned is that, looking for questions here, Don has a question, you can see the chat box. But I think one of the things we learned that we would have not picked up the fact that allografts were problematic in randomized trials, because they're for failure, because they're not a problem if the average age group is 30. It's only when you do a cohort and realize that allografts are fine if you're 30, 35, 40, 45, no difference. But if you look at that high risk group, the right group, if you look at the people in the high school and college, they're a disaster. I mean,
I think you are right. Your cohort drove that train on the allografts. That was one of the early things that you found that I think changed practice. Absolutely changed practice.
And then the Kaiser registry. Then Kaiser has a registry in the United States, ACL registry, and that registry is much, much bigger than Moon. And they're able to they have a 90% capture because of insurance, whether people come back for, if you're Kaiser, you have to come back to Kaiser if your ligament fails and you get reconstructed. So they're granular, found the same data. They can look at which allografts are worse than others. And they actually looked at changing practice and altered practice by showing people data. So I really think that there's some certain circumstances where a cohort's the best information you can get. And again, I think Don Anderson had a good question about, if you don't have the right baseline way back when in a cohort, you're sort of stuck with it. Yeah, you are. But if you design a randomized trial and you don't have a big enough in the wrong population, the randomized trial is negative too. So
I think
really,
like the reproducibility of data issues right now. Many orthopedic and rehabilitation randomized trials have a small N problem. Yes, they might be significant, but are they clinically meaningful? That's a really big,
okay.
big deal.
So we got to, Lynn, can you read the question?
I could read Don's or Brian's. You just told.
Read Brian so that we can get it on the recording. So
it says, can investigators discuss challenges with retaining patients who have good short-term outcomes for longitudinal studies? Do you find that people who are doing well are hard to get back for follow-up? Is there any potential bias to ACL patients who are not doing as well? Brian, are you on? Can you unmute yourself?
Sure.
So you're talking about like people are doing great, right? They go back to sport and they're 18, and 5 years later you're trying to find them and they're, who knows where, right? As opposed to the other way around, where we're worried about following up people who are doing poorly.
Right. I think
is that kind of what you're asking?
Either way, do you find that there are either easier or harder to bring back people who are doing poorly, who have pain, who are dysfunctional, who potentially see the use of being in this study versus some of our ACL patients in that first year or two who are doing really well and then essentially self-select out of the cohort? Do you see either one of those happening? And do you think that potentially the cohorts are maybe biased to one group or the other?
That's a super good question. I don't know. in particular. I know that it's what we found was at 2 years, it was harder. The younger patients, we had a little bit of a harder time getting in, and that may actually be what you're talking about. But at 5 years, we had a whole bunch more that came back. So we're still at about an 80% follow-up. So I'm thinking we're not just systematically missing people, but I really do. Kurt, you and Rick could probably answer this too, but that trying to get those, those 16, 18-year-olds during those college and after years for follow-up is really tricky. But Brian, I haven't noticed a bias toward the ones who are doing better or the ones who are doing worse, if that makes any sense to you.
That's a great question. We're at about 80% overall in looking at patient-reported outcomes of 3,500 at 10 years. And I guess the only way we can infer that is basically we could basically look at the baseline characteristics and risk factors and see if they're different in the group. That's the only way we could, but we couldn't prove it. I know that when we look at failure, so we're looking at people for repeat surgery, our follow-up rates are over 90%. So I even if there's a little bit of bias one way or the other, I don't think it can change the total results. But I don't know. It's a great question, Brian.
It is a great question, Brian. I also think it's very interesting now that we could start to aggregate data. I think we might be able to get that. I mean, I hope that we'll be able to make these data. I mean, Kurt, I have props to you guys. Every time I've asked to be able to use their data set, they've said yes. I mean, if you have a question you want to ask using our data set or using Moon or UK, it would be great. Ask, because I think we would all say yes with appropriate,
I see Rick
ask the question, right, get the appropriate agreements.
Do you have a comment?
Agreements.
Comment, Rick? You're muted.
Rick, you're muted.
Just that, as we all know, follow-up is hard. I can't say that that patients that are doing better drop out. I think it seems to be about the same, but it takes, and we found that Mars is a little harder because you've got so many surgeons involved, so many sites, even though we're doing it centralized for the most part, but it's just not as easy because you're really trying to get a lot of surgeons to help call patients, but it takes, you can get to 60 to 70%, but to get over 70%, it involves for us, the surgeon to reach out to the patient. That's the real ultimate push that gets you over that 70%.
But it's hard to get the surgeons to do those calls. You don't necessarily make friends when you bug them to do that.
Well, but that really has been the success, right? The TDR success of the follow-up that you have is getting the surgeons involved.
Yeah, we think that you can get 65% around there, not maybe 70 with a central person calling everyone and reminding them, but to get the 80% number above that takes personal phone calls by the individual surgeons or their team to the patient to say, hey, please fill it out for us. And that's what gets us over the hump. That's a problem because I don't think that's translatable in the real world. It's difficult to translate in research studies, never mind in the real world to get follow-up. All right, thank you, Lynn, so much. Our last presentation will be by Tim McAlindon, and we're looking forward to your talk.
Well, thank you. Thanks. Can you hear me okay?
Yeah, you're here. You sound great.
Thanks for inviting me. I'll share the screen. Coming up okay?
Yes, it looks great.
Good, okay. Actually, the objective of this talk was really to describe the Osteoarthritis Initiative and its unique characteristics, and then we can discuss data that have come out of it, although those are really abundant. This was a multi-center 10-year observational study, initially sponsored in partnership by the NIH with industry. So it was unique in being an industry federal collaboration. And the goals, as you see from their website, were to enable a better understanding of prevention and treatment of knee osteoarthritis. But another, actually, at its inception, and a pretty explicit goal, was the development of biomarkers of osteoarthritis incidence and progression. And the absence of biomarkers remains actually a substantial technology gap in the endeavor to find effective treatments for osteoarthritis. So this was a ambitious and important objective, and it influenced the design. So this was a multi-center cohort. It was a big study. It enrolled 4,796 adults between 2004 and 2006. And to get an appropriate sample, it was enriched with individuals with or at risk for knee OA based on a set of risk factors. It was conducted at 4 clinical sites across the US with a coordinating center at UCSF. People enrolled had risk factors for knee osteoarthritis, and they excluded people who had end-stage disease or inflammatory rheumatic disease, among other exclusion criteria. Here you see the risk factors, the inclusion criteria, pre-specified age range with or at risk for tibiofemoral OA. It was inclusive of minorities, and exclusions, importantly, were also contraindication to 3 Tesla MRI, because this study deployed MRI scans at each of its sites. So as I said, it was oriented towards biomarker discovery, and to do this, there were annual visits in which there was a comprehensive data collection from participants that included biospecimens, which have been archived, and images, including x-rays, as you see here, and as I mentioned, MRI, which is really the jewel in the crown of the osteoarthritis initiative. They actually deployed new 3 Tesla MRI scanners at each of the 4 sites, and this was a considerable effort and endeavor, and along with that, an extensive quality control and methodology development program. So as part of this, there are extensive outcome data available from the osteoarthritis oriented towards measurements, and these are all available. Here's a nice example of Jeff Duryea's quantitative joint-spaced width measurement. We also have joint-spaced narrowing and many measured outcomes done by people present in the audience here. And, to give you an example, the other end of the range, arthroplasties have continued to be collected. These were data from 2016, 220 hips, 500 knees replaced. So what's unique about this study is that it was entirely intended for public release. So there is a website. Anybody can go there. You can get all the information about the osteoarthritis. This is a screenshot. You can get an account, and you can download databases from all these years of collected information and analyze. So that you can analyze them independently or approach investigators to get expertise. And as a result, there's been a highly synergistic level of productivity that's led to hundreds of publications and spans, the range of, highly image-oriented analyses to, health outcomes and, many important studies. With regard to the specific original objectives of developing biomarkers, there's been considerable involvement from industry and academic groups, really in 2 directions, one with regard to biochemical biomarkers, and the other with regard to image analysis. And I think that these were supplemented by funding from the NIH, and again, many people here are involved with that, and led to quite sophisticated analyses and development of novel imaging techniques to quantify progression. And I'm aware of at least 3 that are currently in the registration process with the FDA, and will hopefully bring us closer towards our goal of having an approved biomarker for osteoarthritis progression that will help us, accelerate intervention and drug development in this field. So yeah, I think I'll end the talk there and take any questions people might have. We can talk about studies that have emerged, anything of interest.
Oh, put the chat box up. Before something, I assume something will come up, I hope, quickly. Tell us a little bit more about the successes and some of the failures of looking at some biomarkers, some biochemical biomarkers for OA.
Yeah, I would say I'm not a basic scientist, and I'm a bit of a I'm more oriented towards image analysis. There are many candidate biochemical biomarkers relating to cartilage turnover or degradation, and a number of those have shown promise. What the FNIH did, and actually David Hunter's here and may be better able to speak about this, was define, using the OAI images, a case definition for progression, and examine the predictivity of these biomarkers separately or in combination as predictors of progression. And they came up with an algorithm which actually incorporated quite a few of the biochemical biomarkers along with a number of risk factors, and we're able to examine the characterization of progression using receiver operator characteristic curves and so forth. So overall, that had I think it was a statistic of about just under 0.7. In contrast to that, the image analyses have ranged from exploring the predictivity of conventional radiographic outcomes, then getting more innovative around bone shape and bone morphology, trabecular morphology, and of course have been fairly comprehensive in regard to all sorts of different MRI approaches to measuring progression, looking at different features, looking at cartilage volume, thickness, and so forth. And in general, those have slightly higher predictive values in regard to OA progression and relationship to symptoms. At least that's my perspective. So, and I think a lot of promise there.
David?
Thanks, Kurt. Yeah, so really appreciate the opportunity to come along, and thanks to Jason and the Arthritis Foundation for being here. Really just to echo what Tim's saying there in response to that question that you posed, Kurt. From the perspective of the FNIH, we looked at the prognostic validity of a range of biochemical and imaging markers, both at baseline but also the short-term change in those to determine those people who were at highest risk of progression. And progression was defined a number of different ways, so both pain, radiographic, and the combination. And I think Tim's summary of those findings is pretty accurate. We had C statistics in our prognostic models of about 0.7, and the major contributors really to that were the imaging markers. And so we're building on that, and as Tim's suggested, we've applied to the Biomarkers Consortium for getting these approved and qualified for use in clinical trials, so that hopefully we can facilitate more efficient trials moving forward. Kurt, do you want me to move on and make, I guess, broad comments about the, the presentations thus far?
Yeah, that would be great. Tim,
Yeah.
is that okay? Tim will let David have some comments, and we have time for everyone to discuss things.
Yeah, so it turned out to be a great segue
Yes.
into David's talk.
You may have arranged that beforehand, for all I know.
It wasn't
Go ahead.
necessarily pre-planned, Kurt, but it's all things end well. But yeah, again, really appreciate Jason's opportunity to come along and listen to a fascinating group of presentations. I think I just want to, I guess, emphasize some of the key points that came from those for me. I mean, there are obviously huge advantages in cohort studies over randomized trials, and some obviously have better applicability and feasibility. But, I think some of the advantages there of cohort studies were enumerated by others, including the opportunity to look at multiple exposures and multiple outcomes in one cohort. I think it also allows you to look at rare exposures, which are often not times possible in randomized controlled trials. Oftentimes, they're also typically less constrained by the eligibility criteria in randomized controlled trials, and as a consequence, maybe easier to recruit and better generalizable to the larger population. And then something that wasn't necessarily mentioned, but I think is really important, sometimes trials are not practical or ethical. Kurt mentioned one example where you can't necessarily do this in some induce a meniscal injury to see what happens to a knee long term, but similarly some exposures like tobacco and alcohol may be less ethical to randomize in the context of a trial. Some of the other points that came out that I think are probably good to emphasize in terms of how cohort studies lead to better randomized trials. So diseases like osteoarthritis that have a long latency, oftentimes having a cohort in advance of that trial can actually give greater confidence in planning for the subsequent trial, but also gives confidence over the magnitude of effects for different exposures, obviously cognizant of confounding and bias that might actually help in pre-planning sample size calculations and doing appropriate power analyses. The cohort studies can often lead to better selection for treatments in randomized trials by clarifying subgroups at greatest risk. And so Tuhina has gave us some focus there around measures of sensitization and thinking about particular subgroups that might be more susceptible to particular interventions that could be applied in the context of clinical trials. And it also, I think, really helpfully provides some idea of the temporal sequence. Again, Tuhina pointed to the fact that their initial hypothesis coming into some of these studies was somewhat disproved after the effect. Likewise, I think some of the really helpful public health measures that Neil mentioned from most, specifically around quadriceps strength, that Lynn really emphasized the fact that, this is something we can modify. I think that's critical in terms of thinking about the temporal sequence of the contribution of that to the development of osteoarthritis as well. And I might just wrap up, and Kurt, I'm not sure whether you want this or not, and I probably should have pre-planned this with you, but think about, where this might lead and what studies might evolve from this. And obviously, one of the benefits of having meetings and discussions like this is thinking about potential collaborations. I think just to emphasize to everybody that's out there, a lot of these resources are publicly available. If not, the lead investigators are usually very approachable and open to collaboration. And there's, oftentimes fantastic additional learning that can come from these shared resources. So just a couple of things that I was thinking about and that may help to prompt some discussion here, Kurt, but again, you just interrupt me if you don't want to go down this road. What cohort studies are needed to advance the science of post-traumatic osteoarthritis? So, having listened to what was presented this morning, particularly from Rick and Lynn about their respective cohorts, if we had someone who comes along who's injured their knee, who is trying to weigh up what treatments they should or shouldn't have, having an opportunity there to have some informed decision made that allowed them to prognosticate their risk of long-term osteoarthritis and the merits or benefits of osteoarthritis, merits or benefits rather of ACL construction when they first presented, based on whether they had meniscal or chondral damage, whether they had persistent inflammation or instability, that would allow us to personalize treatment and decision support and treatment plans in the first instance, I think would be helpful, and potentially something that could evolve from the data that's already there. And I think another really important question from a public health perspective is, we know injury prevention can reduce risk of injuries, but we don't know long term, or at least I'm not aware, that it reduces the risk of osteoarthritis, and because it might be other micro-traumatic instances separate from a major disruption of the ACL or meniscus that contributes to osteoarthritis risk. So I think it'd be incredibly valuable from a public health perspective to actually have some information there about what the long-term impact of injury prevention is. And I think the merits cohort studies are such that both of the questions that I'm posing could come from potentially existing data that is already out there, and maybe people are already doing that. But anyway, I'm going to stop and pass it back to Kurt and open it up for, I guess, a discussion from here. Thank you.
Those are great segues. And I guess in sort of the next phase, we really want to open it up to questions from both the panel to see exactly what their thoughts are. And I guess in a framework, I'd like to say, what should the next cohort studies be? Or number one, that how do we advance the prevention and how do we advance the treatment of osteoarthritis? That's one question to the panel. And then the next question is what haven't we learned out of the studies, or what haven't we thought by the existing studies and data that we should look at it in a different way? So I pose that question to any of the panel willing to take that on.
Nobody's jumping.
Well, I mean, one study that would be interesting that could be done better through an observational study would be having multiple cross sections. Many people who study post-traumatic osteoarthritis select pretty major injuries that occur. Like if you take out the ACL and the medial meniscus and you have other internal derangements of the knee, someone may develop post-traumatic OA pretty quickly. But there are other people who suffer less traumatic injuries. Let's say they're 18 or 20 playing football and they develop OA in their late 40s. It's difficult to get NIH funding to study from the beginning to the end. But if we had a well-characterized cohort where we looked at different people, but at different times, so right around the time of injury, a separate cohort, 5 years, 8 years, 10 years, 15, 20, 25 years later, and connecting those to try to make those connections between the original injury when people are young and when they're in their 40s or 50s, when they're just less young.
Good point.
Good point, Neil. Less young, because we end up with these young people with old knees, is what happens.
Yeah, but it doesn't necessarily happen in 2 to 10 years in a way that we can study everyone together. So having multiple
NIH cycle,
cross sections. Yeah.
I think this is a long haul issue.
Mm-hmm.
There will not be a quick reward for studying all of these people, but I think we really need to do it. It's hard work, and I also agree with you that I think it'll be very hard to get funded. I mean, Kurt, how hard was it, like Moon? Can you talk about?
Yeah, it's difficult. There's no set funding for cohort studies, even now in the NIH. The only cohort studies is a small grant funding that exists, and that's specifically designed to look at the efficacy, potential efficacy, and sort of the clinical improvement and the for randomized trials. So the only cohorts they're funding directly related to that they call for that. So it's hard to get a cohort study funded because there's not a pathway to do that. an easy
But
path.
it's like, it's pretty hard to find. I mean, we both were able to do it through the NIH, but because our 5-year outcomes were pretty tied to the original treatment path they chose. So in your case, surgery, in my case, both, either long-term rehab or surgery. So we could see some tangible outcomes at 5 years or 2 years and 5 years. But to start something where you might not bear fruit for 20 years, in the sort of NIH 5-year funding cycle, I think it's hard. It's just hard. You have to be really, really prescient and be able to write incredibly well to be able to do that. And still then you might not.
David or David Hunter or Tim, or any thoughts or comments, or what are the next things, what are the next things, you had an idea of cohort, what's the next cohort that we need to do that should be looked at or should be thought about getting funded?
Well, I guess what I was thinking in terms of the comments I was making before, Kurt, is do we need new cohorts, or do we need also to think about better ways of analyzing the existing data? I mean, the question that Neil poses there, potentially there's already existing studies that are out there that have data that will actually speak to those questions, and it might be, to the challenge that Lynn, you're speaking to, where it's really very difficult to get funding over such long periods of time. With the existing cohorts that are already there, potentially you already have a lot of rich information that potentially hasn't been analyzed in a way that's going to make the big differences to patient care and decision making that ultimately I think need to happen. I think the other, and this isn't necessarily speaking to this question, Kurt, but I think the other thing that probably needs to happen more is we need to actually implement a lot of the findings that you're already getting that we won't be able to necessarily get from randomized controlled trials. So again, I don't know how many allografts are being used out there still as opposed to autografts, because the knowledge may not necessarily have disseminated all the way through. I think from the perspective of thinking about, again, decision choice when a person first presents, the routine in this country is they all get reconstructed, whether they need it or not. And so I think just some opportunity there for rational decision making and using the existing data, I think would be so incredibly helpful. I see Stefan's come on the screen, and he's probably got more salient comments than I do.
No, thanks. I've been listening to the discussion here. Excellent and very informative, I think. I just wrote a brief note in response to Neil's question about a sort of spaghetti type study where you can pick patient groups in different stages of disease development and follow them all through, but where they're staged 5 years apart or something like that in their development of osteoarthritis. We did that many years ago here in Lund and collected a series of very interesting data on patients that had a meniscal injury and surgery. And Martin Englund then published a series of, I think, very informative papers on that cohort. So yes, that is one way of compressing a 20-year study into, say, 5 or 6 or 7 years.
Stefan, I think those studies, were they facilitated by the presence of existing databases through having a kind of more socialized?
No, we just had our hospital
system?
records. We just used our hospital records in our local hospital. And each of the cohorts was like a couple of hundred patients. Mm-hmm. And they were, so we separated them, we staged them like 5 years apart in their sort of development or in their time after surgery, so that we could sort of generate in 5 years a 15-year follow-up or whatever you would want.
Actually, I guess that is the way things are going here, is the development of big databases from hospital clinical information systems. And the technology that's developing is ways to concatenate the data and provide them into more giant databases. And, maybe those may be the cohorts of the future where we study what actually happens. in hospitals across the US, for example.
Yeah.
Well,
And I, in
So-
turn, sort of got the tip of using that particular design from people in aging research that were using that at the time, now 20 years ago or something.
Yeah, so I guess just a quick comment. I completely agree with Tim that I think the use of electronic medical records and big data analysis is definitely the way forward. The only reservation I have about that, and Kurt, you might want to speak to this, is the depth of those data resources and the consistency around standardized outcomes. But just one way to think about potentially addressing that, and again, this may already be happening internationally. I've seen a lot of different Moon, Mars type replicas that not necessarily collaborating with the parent data set. And again, thinking about some of the subgroup analyses that might inform decision choice and prognostication. What collaboration goes on internationally between different groups who have similar types of methodology in terms of their data collection?
Well, thank you. That's a great question. So we have, we've worked and published several papers with the Della Rosso cohort and Lynn Snyder-Mackler. We have also worked with the Scandinavian ACL registry. And one of the things that became clear to us, and I'm going to address Brian's question because it fits in Brian's questions. One of the striking findings at Moon is that patient outcomes at 2 years seem to be where people are at 10 years. So shouldn't we focus earlier? That's actually true. If where your outcome at 2 years is, the 80% chance you're going to be there at 10 years. And so then we said, is 1 and 2 years any different as far as your patient-reported outcomes, not as far as failure? So we worked with the Scandinavian registry, and what we found in that group is about 8,000 individuals that your KOOS scores, all your subscales are equivalent, not different, but equivalent testing 1 and 2 years. So things that are happening bad are happening early. We ought to study them early, and then the crosswalk. So I think we're beginning to look at data sets, and I think each data set provides us some answer that another data set does. So there's a problem of granularity in hospital records, and the problem with hospital records is you can say that a meniscus is removed or not, but it's pretty hard to get standardization about what else is going on in your knee. How do you, even if I have a group, how do you characterize articular cartilage being injury in the same classification? And how do you characterize what you do with meniscus? So I think each data set provides different levels of data and different answers. And I think the only way you can get the whole picture about how to treat a patient is really taking a combination between, we'll call it registry data and good cohort data that is defined and randomized trials. We have to put the picture, we have to push the picture together.
Yeah, I would agree with what Kurt says. It's a question not of using one or the other. You need the combination of different types of studies. And with regards to cohort studies, my response to the question of what type of studies you need is you need large studies, you need longitudinal studies, and you need studies that really continue long in time. You need patience and passion to run those cohorts for sure, like you're shown, for example, Kurt.
Well, I think that, so I'll just take what I know. Let's take ACL as a post-traumatic injury model. I mean, one of the problems is if you ask kids what they consider what's most important to them, they don't care about arthritis in the future. They're Superman, Superwoman. They care about getting back to sport. I'm not saying it's the right thing, but when they're asked and questioned, that's what they believe. So when we look at ACLs, if I look at the only one really well done randomized trial that was performed, and it was performed in Lund. I mean, that study shows us that there is a group of individuals that do well with non-operative management. There's also a large group that cross over. Well over half cross over in 5 years that don't do well. And so it goes to show you that both are reasonable options for people. Then if I look at graft choice, okay, allografts are not a good choice, but now we've done something to look at saying, is there a difference between hamstring and BTB for failure? And it just took us 14 years to get the answer because we looked at it in the high school and college injured population, 900, and we found out there is a difference. There is a difference between hamstrings and BTB. It depends on age. It depends on the laxity of the knee. depends on their sport. So we built a calculator for shared decision making. Well, that's great. That's one calculator. But then we validated that calculator in another randomized trial called Stability, where there were 600 people that were hamstrings versus something else. And we found out that that calculator works pretty well. So again, it depends on what the question is and who can get at it. If you ask me what's the worst allograft, then I have to go to the Kaiser data, because the Kaiser data has
millions,
4,000, and they know what allografts they are because they can look at. And now we're taking hospital data in. But I think you really have to look at the whole evidence all the way around to put something together. So it's not. I agree with Stephanie. We need all the studies to sort of put together a really good shared decision-making picture.
I also think when we're talking about traumatic knee injury in young athletes, we absolutely need exposure data, and a lot of the cohorts don't have that. So we don't know. They wanted to go back to sport, but we don't necessarily know that they did. So one of the things, the bone, patellar tendon, bone, we published something from one of our other cohorts, not Del Rosso, but our ACL sports cohort, and it turns out that even with like optimum rehab, in order to meet our return to activity criteria, which also include quad strength, it took the bone, patellar tendon, bone folks about 4 months longer than it took the allograft or hamstring. Well, that also means they go back to sport 4 months later, and we know biology matters. So maybe it's not the graft. Maybe it's that they rehab easier. And again, Kurt, we've talked about this with respect to Martha Murray's bear, right? Like, you got to hold them for biology because they feel great, right? They're going to slam their rehab and get back early. So I think that's where for me, I feel like that's where our smaller but deeper data and your cohort that comes back, your in-person cohort that you have, I think will help us answer those questions a little bit more.
So there's a question from the audience. In terms of managing resources and logistics, are we anywhere near a consensus on essential critical measures that could be collected in a longitudinal prospective cohort, assuming that smaller cohorts across countries can't be as comprehensive as the OAI? Kim, David?
I think one of the conundrums of long-term research is by the time you finish the study, all the measures you deployed at the onset are already outdated. So it's a tough one. I think that the future probably is in everybody's pockets, because the amount of data that's being collected on you all the time is immense. And even though we spend all our time as researchers worrying about confidentiality, the amount of personal information that people give away, or which companies like Google impute from your cell phone, is just staggering. It may be that we'll be able to leverage those technologies to track, physical and health outcomes over the long term. And if people, collect information about what interventions that they've had, there may be completely different ways of doing long-term studies. It's weird, I'm being interrupted. I'll decline that. But otherwise, I think you do the best with the data you have. Although, as David suggested, it may be more to do with how we manage the data analytically than what we collect. And it could be that machine learning and other approaches will be able to get more information out than we anticipated.
So yeah, Amanda, it's a great question, and I think a really important one. And I agree with Tim that evolution is playing a role here, where sometimes some measures are becoming antiquated and other new novel technologies are coming along. But I think if you're in the process of starting or thinking about starting a cohort now, and particularly thinking about comparing your data with existing data that's already out there, it's good to see if you can harmonize or standardize with existing measures that are commonly used So you can compare across those cohorts and or pool across those cohorts. Now, there are a number of different activities that are going on in that space or have gone on in that space that provide recommendations about measures that could be used. A lot of those come from clinical trials. And so there I'm thinking particularly around the OARSI recommendations around clinical trials for different studies. I know as part of the Joint Effort Initiative, which is an OARSI group, they're looking at what measures should be standardized across patient cohorts to, again, facilitate harmonization and standardization, particularly around self-reported measures. But I think as Tim's saying, I think when we're thinking about imaging, about biochemical markers, about electrophysiologic measures, about measures of tracking activity, particularly, a lot of those are evolving. And so I think, my general advice for imaging is seek advice from great people who do a lot of this and who want to quantitate that imaging, and get advice about what is the optimal imaging modality to do that in, so that whatever you do will be durable over time. From a biospecimen resource, again, seek advice, but I think my general advice is collect plenty and store, because whatever you do 10 years later may be very different to what you'd recommend right now as far as the measures that you're taking. I don't know whether that was helpful, Amanda, but hopefully.
I just want to say thanks. That's exactly what I was getting at, because, as a younger investigator now beginning to collect samples, the critical issues that are coming up are, should it be plasma or should it be serum? And does that make a difference? And should I collect both? And how do I decide? And that's just one example among the many different examples that I could give. And the reason I ask is because there are ongoing efforts. So the example I can think of off the top of my head is the Canadian Longitudinal Study on Aging. That is a huge endeavor across the country and recruiting thousands of people, and they're not taking x-rays. So it's a bit of a challenge, because that could be an incredible resource, but can there be some kind of concerted effort? I don't know. And I think we're fortunate to have a resource like the Osteoarthritis Initiative and how comprehensive and broad it is. But when it comes to validation cohorts or independent cohorts, I think we're at a little bit of a loss. So starting out and collecting prospectively, this is what I'm wondering. And I wish I had an MRI at my disposal. Unfortunately, I don't. But I appreciate the insights on that.
Yeah, I make a comment. You can never think of everything. The OAI has collected about every biospecimen you could think of, but who'd have thought that it needed also to be collecting poop? And now that's the hot topic.
Who knew, right?
Well, having said that, the advantage in diversifying outcomes among studies is that maybe you can do some cross relationships or figure out what translates to another, changing one outcome with regard to another, and figure out how to impute what the microbiome is doing. I'll give a discrete example. So the WOMAC questionnaire, which we all know and use in long-term studies, was actually developed for short-term studies of non-steroidal anti-inflammatory drugs. And what seems to happen when you use it in the long term is that it loses discriminative ability, at least in trials, to discriminate between groups. And I think what happens is people kind of recalibrate. They've forgotten what their pain was a year ago. So it loses some sensitivity. Recently in trials, some of the pharma groups have been taking a very old outcome, a numeric rating scale or a simple pain scale, but they've been deploying it using electronic technology so that it can be posed on a daily basis. And if you do that, if you get your participants answering questions about pain daily, and then average them over the previous week, it seems like you get much more discriminative validity. So, it could be that using the old measures, but in a new way, we get some more, give them more legs. And, those sorts of things I think will happen in longitudinal studies.
There's a new question that came in and said, is it possible to create a PTOA cohort study on the same scale as OA or most? And what would it take to do that other than grant funding? Would
Well,
like to.
You know, in a way, it would be possible, but not. I don't think it would be exactly like MOST or OAI, which are both 4-site studies. You would need more sites to get thousands of people with knee injuries and get the data all collected in a systematic way. But I think it would be possible because there are currently collaborations between surgeons and non-surgical researchers studying PTOA. And so I do think it would be possible. And Kurt, you know that better than anyone else.
Yeah, go ahead, David.
Sorry, Kurt. Yeah, I guess the comment I was going to make, and it's really just emphasizing something that Tim's probably already made, and looking at the way healthcare is evolving, and thinking about both within country but also cross-country collaboration, is I think the use of standardized outcome measures as part of electronic data collection in routine visits is becoming much, much more commonplace. And, you know, assuming people have regular follow-up visits that occur over time as part of a pre-planned follow-up following a procedure, I don't think it's insurmountable to think that we could actually use electronic medical records with built-in templates for using patient-reported outcome measures that are there over time. And I think one of the changes that's happening in clinical care, and traditionally we've, I think for healthcare delivery, been very focused on activity-based funding. So everybody gets paid according to what they do, not necessarily according to the outcomes we attain, or not necessarily according to the quality of care that's delivered. But I think there's a big shift going on looking at outcomes-based payment as opposed to necessarily activity-based funding. And I think one of the impetuses of that change will be that may drive us towards more standardized data collection so we can actually capture the quality of the care that we deliver. And whether that influences this or not, but it may actually allow opportunities for us to collect larger data sets, assuming we have quite standardized protocols across a number of different sites that would allow the rich data that we actually want to pursue.
I think that I certainly agree with that. So Neil, I think it's an answer to Matthew Hark. You answered the question. I think it is possible to do. And I think it's very possible to do. I just don't think there's the cluster. Forget about funding. Forget about funding aside. Just the cluster of expertise that has to be put together in order to do a large PTO study. It hasn't been assembled yet. And so that you really need to do it right. You really need, you need the imaging experts, you need the biomarker experts, you need obviously the clinical experts, and you need, the biologists, and you need those individuals to say, okay, what do we have to collect as a minimum? Is there a minimum data set we can collect versus what's the ideal data set? And to work it out. I don't think we know. Maybe there are biomarkers that should be explored that we learned about in OAI that maybe we should explore in a PTOA model. I don't know, but I think it can be done. But I think that it has to be put together by a group of individuals that are dedicated to looking at it. And I think the Arthritis Foundation might be a great vehicle for that in the future.
Kurt, I'd like to resonate with that and also with David's comments. I think that if you put together the opportunities offered by electronic medical records and standardized data and outcome collection with a kind of network of investigators to set up a coordination of data accumulation such that, the funding is not now for one center to do a trial. The funding is for the network. And you could actually kind of replicate an OAI type scenario where you have a bunch of centers that agree to participate by providing the data. But what you fund is the coordinator or coordinators to go among them, standardize, set up the systems, and accrue the data. And on top of that, you need to imbue among the surgeons a similar mentality to that of oncologists, where everybody who comes along should be enrolled in a trial, because we don't know what the best treatment is and we need the data. So everybody gets enrolled, the data go in automatically, you have a network that helps coordinate those activities and bring together a centralized repository. And there is a precedent for this. There's actually a network through CTSIs, the TIN network, that's specifically set up to brainstorm and set up collaborative multi-center studies. So, I think there could be mechanisms there, and it's just a slight, change in heuristic about how the study is structured, with not a major change in necessarily what people do. And then, you might start simple with a fairly basic database, but I think once you have that, people will come to you and they'll say, I'd like to bolt on this analysis of this biomarker or this image. And then you can acquire more funding through sort of satellite grants, pilot studies, and so forth to help, build momentum to the whole project. That's how I would envisage it growing.
Yeah, I agree with Kurt and David and Tim's comments. In addition to what Kurt was mentioning about assembling the experts to make the study really impactful and viable, where you recruit them probably matters too. And one of the reasons that most was so successful with retention is that in Iowa and in that community in Alabama, people don't move around so much. In Iowa, it's farmers. If one person says, let's build a barn, they all say, hey, let's go help them. And so people stay in the same place and are very altruistic about following up over time. So following people in the electronic medical record is excellent. And even if someone moves to another site, maybe we could still capture that. But I think assembling cohorts like this, the specific clinical sites that are selected can be important in retention to have longitudinal data.
Hey, Kurt.
Yes.
This is John. Yeah, how are you doing? You guys got my attention. We started talking about patellofemoral disorders. This is John Elias at Cleveland Clinic. So I think just that the people that I talk to are very interested in this kind of stuff. So I think the finding the right group of surgeons that would be interested in participating in a patellofemoral PTOA database. I think the people are out there. I think there's a lot of interest in it. Obviously, patellofemoral issues are very different from tibiofemoral issues. Obviously, you got the relationship with patellofemoral related to ACL injuries, but then you've got the whole different population of patellofemoral dislocations and the traumatic injury to cartilage and how that propagates and so forth. So I think, in my opinion, it's a little more complex of an issue, just in terms of how the many factors that can contribute to it. But I think the people are out there. Kurt knows we've been trying to we've got a little group together at Cleveland Clinic, and when we start to present our stuff around, we've got a kind of network of people on Northeast Ohio who keep expressing interest in contributing patients and letting us, being part of the group to start to characterize some of these issues related to patellofemoral disorders. We've got a good imaging people, good surgeons, and hopefully a good biomechanical engineer. But I think there's people around the country who would like to participate if we could find the mechanism.
Thanks, John. I agree. So Brian asked a question about, his question was, most cohorts follow clinical time points 6, 12, 24 months post ACL. Is this good enough moving forward to collect the most relevant biologic outcomes of interest, or would it be different as far as temporal resolution? So
let me just come in here just real quick, Kurt.
Yeah.
Because I think you made a really good point about your 1-year data and your 2-year data being virtually indistinguishable on patient-reported outcome measures, right? Not just similar, but pretty much the same. I think if it were me and I were designing like the what I think would be the perfect study for post-op ACLs and PTOA, I'd collect even more data in year one.
Yeah, I think
to try and figure out what are the players, what are the things, time zero, time of surgery, and then during their rehab, which is, you know, maybe 6 months if we're lucky, that are driving. We need a whole lot of people, but I think we could. I think that's the time frame, as opposed. I don't know, Brian. I don't know what you think, but that's my 2 cents.
If I can add a quick comment, Stefan speaking.
Yeah.
If you look at the molecular biomarkers and the MRI biomarkers for changes that happen during the first 5 years, most of them happen in the first 1 to 2 years, and then things seem to plateau. However, if you want to monitor osteoarthritis development as assessed by plain radiographs, you need 5, 10, 15, etc. year follow-ups.
Let's see, chat. How do I do that?
It's Nancy Lane.
Hi. I have been jumping in and out because I've been teaching simultaneously. But I like that comment, Lynn and Stefan, but I want to challenge it with something else. I believe the first 2 years are different than, say, 5 years out. But I also think the plateau is probably different for many, many patients. So I don't know that that helps us, other than to say that we have to better understand the heterogeneity as people go into their recovery.
Yeah, I think you're dead on.
And I also think it's going to be sex. It may be differ by sex too. Okay.
It might be. I think that we don't control their activity levels. We don't really have a good handle on that, and so I'm hoping that some really smart engineer creates a usable, wearable device that people would actually wear, and that we could figure out how active they're being or not being.
That's a super good idea, Kurt. And actually, I think the technology's there now, and I would challenge people as the new year begins, and I hate to say it, but hopefully people will go skiing, and if they have an accident, we could pop some activity monitors on them and get some data. I think that's a great idea. We could do that now.
So we can't.
If Ivanka Lightly's on this call, I think she might have something to add to that.
Maybe I don't know whether they're there or not.
She saw her when she came in at some
point.
So
one of the problems with the current level of activity monitors, whether people will use, whether it's the Fitbit or some of the commercially available ones, is that they're not research grade. They're not there. They can say whether you're very active, moderate active, but they may be off by 1,000 or 2,000 steps in a day. And so that's the problem that we need. We need something that is, and the actigraph is accurate, but no one will wear this big clunky device on their hip. We tried the actigraph on people after ACLs, and they would like play with them a little bit, and they would use them. But when they went back to sport, they're like, I can't wear this and play basketball.
Well, Kurt, I just purchased some that actually have a chip in there around the wrist that's 30 days. That lasts 30 days, and I'll get you that information. And they're not too clunky. There is a middle ground, but they're a bit expensive, but they're accurate. They're accurate.
It would be nice.
And I think we're only a couple of years, maybe not even that, from a really amazing IMU. That we'll be able to tell all kinds of things. They'll put a little Band-Aid on the thigh, a little Band-Aid on the shank, and we'll get kinematic information.
Yeah, which is really important. Yeah.
So the other information that just one of the questions came through, there's a small but mighty, as Lynn says, PTOA cohort study ongoing. This publication provides some preliminary protocols in the chat. There are several papers on this, and it's referenced in the chat that anyone can see it and look it up. So thank you, Jackie, for letting us know about that. I would like to implant the activity monitor truly when you do the surgery. Like it comes with the knee or the ACL, but I don't think the IRBs would like that. I don't think it would go over. No, it's in reality, that's what Google does with Google does on your phone and everyone else.
Well, Kurt, I don't think that that's too far off. I mean, I think that we're almost there. They'll allow.
Any from the panel, any closing remarks? We're a few minutes away from 2:00. Any closing remarks or comment, anything that's missed or things that you want to highlight or you want to say?
I
just said, I think this has been a wonderful discussion. We have quite a panel here of folks who have been really pioneering this kind of work in orthopedics. You know, it's not, as I said before, it's not really sexy, right? People don't die from this, but the burden of musculoskeletal disease is enormous on people's lives. And I think we're all collectively trying to make that burden less. So.
Yeah, it's an incredibly important problem. I really appreciate the opportunity to come along today and just encourage everybody who's out there to think about, I guess, new ways of looking at existing data and collaborating and pooling across those existing data sets, as well as novel ways of potentially networking across different sites for electronic medical records. And just to, I guess, re-emphasize something that Lynn and Stefan were saying is really just to try to get as granular data in that first period as possible, because I think if we can better understand that initial, probably 3 to 6 months prognostically and from a decision choice, I think that's probably where we need to be focusing.
I agree. I think we have an enormous amount of data from a number of studies that have been conducted. And I appreciate the Arthritis Foundation putting together these forums where people can network, get to know each other, and hopefully find better ways to look over the data, because there's a tremendous amount of data that hasn't even been examined yet.
Stefan, any comments? You've been in this, you're an expert, a world expert in this. You've been doing this a long time.
I enjoyed listening to the conversation and the generation of new data that you continuously bring on. And I think we need the data, but we also need, as someone commented on, we need not only new and more data. We need to actually understand what to do with the data we have. And I think there is a lot of untapped resources in these different cohort studies. And I think that getting together between these investigators who are leading these cohort studies and actually sitting down and trying to work out collaborative projects where actually the data from these different cohorts could be harmonized and brought together as one big meta cohort, so to say. I think that would be really important, as well as, generating new data as we all are.
Well, I think that was, I think you summed it up much better than I could sum it up. And I think that's terrific. I certainly agree with that.